pleasure to have this opportunity to share my work with you all. And so this project actually is in collaboration with my co-authors, Dr. Erin McDuffie, Professor Randall Martin, and Professor Michael Brower. I would like to express my gratitude to my co-authors for their support throughout this project, and I would like to many thanks to my supervisor Michael Brower, who supports me while I was at UBC, and he continues to offer me many like ongoing supports on my other projects. So really appreciate his support. And today I will be presenting the economic impact of ambient PM 2.5 from combustion sources and how understanding these economic costs will lead us to make better policy decisions in terms of mitigating health and economic impacts from both air pollution and climate change. So today my talk will focus on these basic structures. First, I will begin by talking about the motivation behind this work, and then I will move on to the research questions that are focused in this project. And then I will further explain the methodology used in this study. And after that, I will talk about the results and key findings. Finally, I will conclude with some key takeaways and the future directions of future research. So, first of all, what are combustion sources? Combustion sources refer to any process or activity that involves burning of fossil fuel or biomass. So basically, according to this definition, you're probably immediately thinking about fossil fuel combustion in transportation sector, power plants, residential cooking, industrial processes, production processes. And if you live in Vancouver, you're probably not going to be unfamiliar with the wildfires. These are all combustion sources that influence both the air quality and climate change. And then in this study, we basically focus on 6 primary categories of combustion sources for better identification. So we categorize all these sources in different fuel types. So first of all, we estimated the effects of total coal, solid biofuel, liquid oil, natural gas, agricultural waste burning, and other fires. Here, other fires refers to the deforestation as well as the wildfires burned in the forest or the peat, etc. So all these are considered as the categories of other fires. And then the last one is AFCID. The full name is super long, which is anthropogenic fugitive combustion industrial dust. And this is a tricky source because it includes both combustion and non-combustion sources. Yeah, and then 50% of these sources are basically we simply assume that 50% of these sources are from combustion sources. This is because the ambiguity of this source is hard to disentangle which source is from combustion, which is non-combustion. Therefore, we just make that very simplified assumption. And after we define combustion sources, next is the key question is why combustion source? Why we focus on it? So basically, combustion sources contribute to significant portion of air pollution emissions and greenhouse gases. Therefore, it has double impacts, both climate change and health impacts. And more importantly, therefore, it means that climate actions targeting combustion sources can generate large ancillary health co-benefits from air quality improvement. So these policies that understanding the health costs from combustion sources can help us to better define and design the regulation policies targeting both air pollution and climate mitigation efforts. And then another reason why we focus on combustion sources is that there are growing consumptions of fossil fuel and biofuel energy. Therefore, these sources are contributing more and more emissions into the atmosphere that raises growing concerns. And there are also emerging sources like wildfires. Because of climate change, the frequency and intensity of wildfires increased over time. And how do these sources influence our health is important questions that needs to be clearly answered. So in this case, we further wanted to emphasize that air pollution combustion sources is a significant contributor to the PM2.5 concentration and also generate large health costs. So according to our previous studies shows that PM2.5 generally associated with 4 to 8 million deaths each year, and that can be translated to $2 to $8 trillion in health costs. And more importantly, the exposure to PM2.5 pollution disproportionately affects the older population. And given this rapid aging rate of the world population, the exposure of air pollution becomes a bigger issue. And in the following figures, it shows clearly how air pollution disproportionately affects the older group. For example, if the air pollution increased from 10 to 35 microgram per cubic meter, the attributable mortality to the population for the population older than 60 years old will be more than was more than 10 times larger than the attributable mortality for the populations under 60 years old. And therefore, the substantial disproportionately effects on the older ones. And more importantly, we found that globally, health costs on population older than 60 years old accounted for more than 60% of global health costs from PM2.5 pollution. And then most importantly, many of the regulatory policies actually designed targeting certain sources, like different source of pollution or like different fuel types or different sectors. So all these policies need some source specific information to support their policy design. And then previous studies have implemented many kind of experiment or modeling to understand the source apportionment of PM concentration as well as the source apportionment for the disease burden. However, these studies are valuable. However, for policymakers, sometimes they need more direct information to conduct accurate cost-benefit analysis. Therefore, understanding the health cost from specific combustion sources can provide more straightforward information for decision making. And according to Clean Air Fund and climate policy initiatives, it shows that there is a very small portion of global funding that are designated to support air pollution and climate change programs. Therefore, this is also the same for many government program or government policy fundings. Therefore, we have very limited resources to mitigate air pollution or mitigate greenhouse gas emissions. And this emphasizes even more that we need to figure out a way to maximize the benefits of air pollution and climate change mitigation. We also need to minimize the cost of implementing these policies. And then, given these above research backgrounds, I wanted to emphasize that it is paper, we wanted to focus on two key research questions. First is what are the health costs associated with the PM from combustion sources, and the second is which sources actually should be prioritized. And this paper, we basically applied 4 major steps to quantify such health costs. First, we estimated global disease burden at 0.1 by 0.1 degree. In other words, equivalent to 11 by 11 kilometers at the equator. And then we translated this disease burden into health cost using age-adjusted and age-invariant valuation measure as a sensitivity analysis. And then we further decompose the major driving factors that affects the variations in health cost per capita across countries to understand which factor actually played a bigger role. And then lastly, we applied a zero-out approach to analyze the source-specific contribution to relative risk, deaths, and health costs. So let's first look at how do we actually estimate the global disease burden. So we basically applied a MRBRT splines from global burden of disease in a study in 2019. And then after we estimated the relative risk, we estimated the attributable deaths using baseline mortality times the attributable fraction of the PM concentration, pollution, and then times the population size and the co-exposure factor. Then we calculate the total deaths from given cause, given age group. And then here, co-exposure factor is a adjustment factor that can isolate the effects of household air pollution and ambient air pollution. As this study will focus on ambient air pollution, therefore, we wanted to multiply this factor to exclude the effects of household air pollution. And the higher co-exposure factor means a higher contribution of ambient air pollution to the disease burden. And the lower exposure factor means that the ambient air pollution contributed a lower share. And here, this figure basically illustrates the common shapes of MRBRT exposure response functions. And basically, we can see that most of the MRBRT splines demonstrated a concave shape, where the slope of the exposure response function can be steep when the air pollution is low, and the slope gets flatter and flatter as air pollution increases. And this sort of illustrates the basic patterns of how the relative risk increases or changes in response to the change in PM concentrations. And then we also can see from this figure that the pattern or the shape of the exposure response functions actually varies across different age groups and different causes of disease. And these variations or the different patterns of exposure concentration response functions illustrates the complicated relationship between the PM concentration and the relative risks for exposure population. And next, we move on to how do we actually estimate the health cost using age-adjusted and age-invariant value statistical life measure. And now it comes to my first poll question. So basically, I wanted you guys to make a guess what is actually the value of a statistical life. Okay. We have 60% participated. Should I wait a little more? Is this such a difficult question?
Yeah, how we have stopped the poll.
Oh, I see. Okay, so basically we have 60% people participated, and then I see that most of you chose the first option as the answer. And then for those of you who choose the answer as the option is actually the correct answer. And then let me go through why option D is correct answer while the others are not. So basically, the while social life is a marginal trade-off between the fatality risk and the income population's income. And then for the first option, which is the value of one's life that the government places on its population, is not correct. This is actually one of the most common misinterpretation of value of social life, that many people believe that when the government publish a value for the value of social life, it means that the government places value on its population. And this is not correct, is because value of social life is not what government decides. It's basically decided by a collective preferences of a general population on their marginal trade-off between their mortality risk and their income. And therefore, value of social life is not determined by the government, and this is actually a value reflected by ourselves. And the second option, the total income earned by a person over their lifetime. And this is a common estimate as an alternative value for a value of social life, but its value is definitely much lower than the value of social life because it does not consider other intangible factors. And this method is often used in the human capital approach, which basically captures the productivity of a person's life over their lifetime. And then for the third option, it calculates the medical cost, and this is often used in cost of disease approach that captures the direct cost related to a certain disease or the amount of money used to save one's life through the medical treatment. And both option B and C offers you a lower estimate of your value of social life because the both options do not consider the intangible value of losing one's life. Basically, it does not consider the suffering, the pain, and the sorrow and the emotion feelings that you have for losing one's life. Therefore, value of social life captures a higher bound or higher value of one's life, one's statistical life, sorry. So that is the first pool, and I hope I'm clearing your confusion a little bit about the value of social life. And then now we know what is value of social life. How do we actually measure value of social life? So basically, let's take a very easy example here. Let's assume a city has a population of 1 million people live in the city, and then each individual is willing to pay for $10 for a policy that can reduce their mortality risk by 1 in a million. Then how do we estimate the value of social life? So basically, if everyone's willing to pay is $10, and then we have 1 million people in this city, means that in the whole city, the mayor can collect $10 million to implement this policy. And then how much risk can be reduced collectively? So that is the aggregated risk across the whole 1 million population, which means we multiply 1 in a million times 1 million population. That is the aggregated risk avoided by this policy. So we use $10 million divided by 1 million times 1 in a million, which gives us a $10 million for the wild social life for the city. So that is the mathematical mathematical approach that we estimate a wild social life. It sounds pretty easy, right? Mathematically, you just use the total willingness to pay divided by the aggregated risks. However, theoretically sounds easy, but the difficult part is how do we actually derive the individual's willingness to pay? For any goods in the market, through our Econ 101 course, we know that every price is determined by the supply and demand in the market. However, there is no market for our lives. There is no market for risk reduction. How do we determine the willingness to pay for risk reduction then? So economists basically use two large categories of approach. One is stated preferences. Basically, this approach means that the economists create a hypothetical market for you, and then they ask you how much you are willing to pay for a unit risk reduction, and through a questionnaire survey. And then this kind of survey can be implemented for everyone in the city, and then we can average out your willingness to pay through this survey. And the second approach is a revealed preference. Basically, we instead of creating a hypothetical market, we actually determine your willingness to pay through your actual choices in your daily life consumption. For example, you choose to take a job offer that has higher occupational risk but higher salary. It means that you are making trade-offs between your health risk and your income. So you are willing to give up some of your risk for higher salary. So that is the revealed preferences. And basically, using these two approaches, we can derive population's willingness to pay. I won't give you too deep about these two methods, but if you're interested, I'm happy to chat more afterwards. And then that is the definition of social life and how we measure it. And now I wanted to explain a little bit why we use age-adjusted wild social life primarily in this study. So this is basically because wild social life actually change by age, although this is under debate by many economists, but most of people actually agree that wild social life theoretically and empirically, they vary by age. And in this study, I primarily consider three major factors. First is the life expectancy. Basically, the greater your life expectancy is, the higher willingness to pay you are higher willingness to pay you have for a unit risk reduction, because you're literally paying for more life years expected in the future. Therefore, your willingness to pay is higher if you have more years to live. And whereas if you are like in your 80s, 90s, you are having fewer years to live, therefore your willingness to pay tends to be lower. And therefore, for younger people, their willingness is higher because they have larger life expectancy than the older people. And that is why one reason why wild social life might vary by age. Second is life quality change your willingness to pay for risk reduction. So the higher quality of your life, you're more willing to pay to reduce your health risks. And then if you have a low life quality, you are less willing to pay for risk reduction. Therefore, for young people, generally they have better life quality, and whereas for older people, their physical health degraded and they don't have as much flexibility as before, so they don't enjoy life as much, and they probably have some pre-existing disease already, so their life quality declines, and their willingness to pay also decreases over time. And then income also influences your willingness to pay for risk reduction. For example, if you're super rich, you're willing to allocate a lot of resources to protect your health. However, if you're low income, you are less willing to allocate much money to avoid risks because you have more things to worry about. You need enough food, you need some clothes, you need a shelter, etc. So those things influence your willingness to pay. And for a young person, they just graduated from college, very little experience. Therefore, their willingness to, they have very low salary. Therefore, with a low income, they have very limited resources to allocate for risk reduction. However, for older people, they have worked in the industry for decades. They gained so much experience. They have greater salary than young people. Therefore, they have more resources to allocate to protect their health. And therefore, for income, the older people tends to have higher willingness to pay, and young people have lower willingness to pay. So given these three factors, it comes to my second poll question. At what age do you think the value of social life? Sorry. At what age do you think the value of social life will peak? Okay. So it seems like most people chose 40 to 50 years old, and then people's value of social life will peak. Um, so in this study, the peak value of social life actually reaches at age 50 to 60 years old. And I won't say those of you who chose 40 to 50 is wrong. If you look at the research study published by Viscusi 20 years ago, it actually says US value of social life peaks around 40 to 50 years old. But given the longer, a higher age for retirement, I believe if you reconduct this study, it's probably going to increase a little bit as well. So basically, in this study, we found that while social life peak at 50 to 60, and this is definitely the interaction between the life expectancy, life quality, and people's capability of people's wealth. So basically, if you look at Canada, it's around 55, 54 years old, the wealth social law peaks, and China is similar, and US is a little higher, but not much, around 55 years old. I wanted to emphasize that using different valuation methods, the peak age might change. And again, this is only the results for this study. And if you use different valuation methods, you probably have different results. And that sort of summarizes the value of social life. And basically, I wanted to wrap up how do we actually calculate the age-adjusted value of social life for each country. And what we do for one thing I wanted to explain is that in this study, we don't have the country-specific water social life because most of the low-income countries, they don't have any estimates for water social life. Therefore, in this work, we use the water social life, base water social life from OECD countries, and we assume that people's willingness to pay is proportional to their GDP per capita at exponential rate, which is determined by the income elasticity. And then the wealth social life from OECD countries actually based on a meta study for over 300 cohort, 300 contingent valuation study. So that is probably one of the most common used base wealth social life in this kind of study. And after we calculate, adjust the base that wealth social life from OECD country according to the GDP and exponential to the power of income elasticity, and then we adjust it by the ratio of life expectancy and the ratio of wealth weights, and then we calculate the age-adjusted wealth social life. And then after we get the age-adjusted wealth social life, we times the age and cost-specific deaths from PM2.5 pollution. We calculate the health cost from each cause and age group. And next, I wanted to talk about how we decompose the major driving factors. We basically used the methodology from Global Burden Disease in 2019, and that is originally developed. That method was originally developed by Das Gupta in 1993. And then basically the method we use to compare the health cost per capita from combustion sources at each individual countries versus the global average health cost per capita from combustion sources. And then we wanted to understand how does each driving factor drives the higher or lower of the health cost per capita comparing with the global average. Basically, we decomposed the driving factors into 6 factors, and we have the PM2.5 exposure, we have the source structure. Basically, we capture the total combustion sources. And then for the third factor is a co-exposure factor, and the fourth one is the baseline mortality, and the fifth one is population aging, or can say is population structure. And the last one is GDP per capita. Except the GDP per capita, all the other factors can be adjusted to improve the health effects. Whereas for GDP per capita, I sort of feel the higher is better, even though higher GDP per capita tends to increase the total health cost, but also a higher GDP per capita it refers to or implies that people's willingness to pay for risk reduction is higher, which means countries can allocate more resources for pollution abatement. And the last one is source apportionment. So basically, we applied a nested zero-out approach to quantify the source apportionment to health cost, relative risk, and deaths. So here I wanted to take health costs as an example. So basically, I calculate the health cost from all from PM2.5 from all sources, and then I calculate the health cost from PM concentration that removes the certain source. And then we use the total health cost minus the health cost without a given source. That gives us the avoided health cost after removing certain source. And therefore, the health cost contribution from given sources can be calculated as the avoided health cost from a given source divided by the sum of all the avoided cost from all sort of individual sources. That gives us the source contribution to the total health cost. So that sort of summarize everything, the key methodology we use in this study. And now let's move on to the results and findings. So basically, you find that PM2.5 was associated with almost 4 million deaths each year in 2019, and then that disease burden actually incurred around $2 trillion health costs, and combustion sources accounted for 56% of the total health costs. And then if you look at figure A, you can notice that the health costs from combustion sources varied substantially across countries. And basically, China, India, and US demonstrated the largest health costs from combustion sources. And then for figure B, I illustrated the top 6 countries with the largest health costs from combustion sources. And then beneath each country's name, all those percentages represents the health cost, total health costs in each country relative to the global health cost. So notably, we see that China, the health costs from PM pollution in China accounted for almost 40% of the global health costs. And among combustion sources, so in China, total coal is introduced the highest health cost, whereas for India and Indonesia, the solid biofuel contributed the highest health cost. And then for United States, Russia, and Japan, liquid oil and natural gas played a dominant role in increasing the total health cost. And again, these health costs with respect to each source represents the health benefits if we remove these sources. So if we can implement targeted strategies, for example, phasing out coal in China and eliminating biofuel in India and switching liquid oil and natural gas with renewables in the United States, altogether these 3 measures policies can generate $280 billion each year, which accounts for 25% of the total global health cost from combustion sources. And if earlier I showed you that health costs from China, India, and US is extremely high, and that is sort of related to the population size, because the larger the population, the higher the health costs from PM pollution. That does not capture the full picture. So we further standardize the total health cost by dividing the health cost with divided the total health cost by the total population, and we calculate the health cost per capita. So on average, the global health cost per capita from combustion sources was $147. And then this value range varies substantially from 1 cent in Marshall Islands to $660 in Hungary. And then if you look at this figure on the right-hand side, basically the log transformed health cost per capita from combustion sources was positively linearly correlated with the log transformed GDP per capita. It basically means that the higher GDP per capita, the higher health cost per capita from combustion sources. This is largely driven by the higher quality of life in the higher income countries. I want to emphasize that the higher wealth of life in higher income countries does not mean that we devalue the lives in lower income countries. Instead, we wanted to make sure that the health costs reveal their preferences in lower income countries. For example, if we use wealth of life for like Syria in for the well-social in the United States to estimate the house cost in Syria. It means that they have substantial house costs, whereas the government doesn't have enough budget to implement any policies to regulate this pollution. Therefore, understanding or estimating the house cost in each country according to their local government resources is extremely important to help them to allocate resources efficiently. So basically, while social life is higher means that your willingness to pay is higher, whereas while social life is lower, it means your willingness to pay is lower. It doesn't mean that your life worth less than other people's lives. And then we also standardize the house cost relative to the GDP. And then here, the y-axis is the percentage of house costs from combustion sources relative to the national GDP. You can actually consider like what is the percentage of house costs relative to each dollars of GDP earned in the country. And then the x-axis is the GDP per capita. Basically, you can see that the upper middle income countries tend to have larger percentage of house costs relative to their national GDP. It means that these countries sort of like treating their environmental quality or health, public health for a better economic development. And these countries sort of like includes Bulgaria, Romania, Hungary, and China. So these countries sort of like experiencing a larger percentage of house costs relative to GDP. And then I mentioned that even though like from the like these two graphs, we see that even though we control the GDP per capita, there is still a lot of variations across countries' house cost per capita from combustion sources. It means that there is still a lot of factors we haven't captured to understand what factor actually drives the changes or variations in the house cost. So we decompose these driving factors, including the PM concentration, co-exposure factor, soil structure, etc. And then in this figure, I selected 16 countries to illustrate you how these factors actually affect these countries' house cost per capita from combustion sources. And then for those dash orange or golden lines, it represents the global average house cost per capita. And then for the positive values, it means that the corresponding factors driving the house cost per capita in the corresponding country larger. And then whereas if you have negative values on top of the bars, it means that these factors actually decreases house cost per capita in a given country. And then if you look at China, actually PM concentration and population aging played a dominant role in increasing the house cost per capita in China compared with global average. And then for India, PM concentration and baseline mortality played a dominant role. And then if you look at Canada, actually the source structure and the population aging played a larger role in terms of driving the house cost per capita in these countries up. And then
sorry, sorry. We'll have to wrap up in 2 minutes, I think, so that we can have some time for questions.
I still have
Thank you.
lots of things to talk, but let me quickly wrap up. So basically, if you summarize the driving factors, actually demonstrate some patterns where if you look at a PM, the effects of PM 2.5 with respect to the GDP per capita, the effects of PM 2.5 get decreasing on the house cost per capita. Similar patterns for mortality. And whereas for GDP per capita, population aging, co-exposure factor, they tend to have a positive relationship. And then I wanted to emphasize that in this study, we observed some disparities between the source contribution to health costs and source contribution to PM concentration. And then we defined the disparity as the percentage in the combustion source contribution to health costs minus the percentage contributions from combustion sources to the PM concentration, then divided by the percentage change to the PM concentration to calculate the disparity. And then we can do this for other resources as well. Basically, positive disparity means that the health cost, the source contribute a higher percentage health cost than their contribution to concentrations. And then I don't think we have time for the poll anymore. But actually, globally, total coal demonstrated the most positive disparities, which means that phasing out of coal is extremely beneficial. And then we also observed some positive disparities for combustion sources. Globally, combustion sources demonstrated 2%, more than 2% positive disparities, whereas if you look at regional disparities is much larger. It means that in all these regions, phasing out combustion sources can be more beneficial than its contribution in air pollution reduction. And similarly, we find in each country, the combustion sources demonstrated positive disparity, whereas for the North African countries, the wind-blown dust played a dominant role. Therefore, the combustion sources demonstrated a negative disparity. And we also observed a similar pattern at grid level. For local governments, it's important to implement targeted policies to phase out pollutions that can generate larger positive disparities. And these disparities largely driven by the nonlinear relationship between PM concentration and the concentration response functions. And the pattern was not really clear because of the complexity of this estimation procedure, but the key message here is that concentration response function played the nonlinear relationship between PM concentration and health cost played a dominant role. And some key takeaways is that combustion sources contributed 56% of the health costs, and then the high-income countries can experience larger health benefits by phasing out liquid oil and natural gas, whereas low-income countries can phase out coal and biofuel. And then many positive disparities are observed, and the combustion sources mitigation can be more beneficial than targeting non-combustion sources. And for future research, I wanted to emphasize that more studies should be focusing on time series analysis and marginal benefit cost assessment, and most importantly, how these effects actually affect different groups of population. So that source concludes all my talk today, and I'm happy to take any questions you may have.